it's almost a spherical structure which is around 24 millimeters along a particular axis, what we call as axial length from the cornea to the retina. That particular axial length, if it is going to exceed 24 millimeter, we have a set of disorders, refractive errors called as myopia or short-sightedness. And once the axial length is short of 24 millimeter, we get what is called as hyperopia or long-sightedness. As far as the corneal, the anterior surface of the eye, there is a transparent structure, what we call as the cornea. When there is a discrepancy in the vertical and horizontal meridian of the cornea, we get something called as astigmatism, where you don't have a single point focus on the retina, but you have multiple foci of images that are formed. As far as this myopia, hyperopia and astigmatism is concerned, that again forms a major chunk of your eye disorders. More so, and a proper diagnosis at the proper time is required to give a perfect vision for all the subsequent years to come. So if you want me to explain each of this thing in detail, if we can just analyze this picture of myopia. So what really happens in myopia or short-sightedness is, the eyeball, as I said, once it is elongated 24 millimeter, you see here that the image is not formed on the retina, but it gets focused in front of the retina. So what we do for myopia per se is, we give the patients concave lenses that try to bring the image back to get focused on the retina. Then the next one, as I said, was the hyperopia. The hyperopia is where the eyeball is not 24 millimeter. The growth is not 24 millimeter as far as the axial length is concerned. So the light rays still think that the retina is at the end of 24 millimeter, and ultimately they overshoot the retinal barrier and the image gets focused behind the retina, and that is hyperopia. Astigmatism, as I told you, instead of a single point focus, single sharp image focus on the retina, you have multiple foci that are formed. That is astigmatism. Yeah, they are the refractive errors: myopia or short-sightedness, hyperopia or long-sightedness, and astigmatism or the cylindrical error.
But can they have a combination of any one of these?
Absolutely. See, the myopia can be a combination with, you can have a combination of myopia with astigmatism. Again, hyperopia can come with astigmatism. Definitely a combination is possible. And whatever is the axial length I have mentioned is only a type of this myopia or hyperopia. You have curvature myopia, index myopia. Due to various other pathological features in the eye, different types of myopia are also present. But on the whole, the commonest is more to do with the axial length. So I'm just mentioning only about the discrepancies in the axial length and the refractive error. But various other types of myopia are also possible. Yeah.
And if one starts wearing spectacles, does the power keep increasing? It stagnates, or what is the course of things when they will start wearing spectacles, and what age? That is, I think, more important.
Right. What you're asking is a very valid question. See, per se, you have to understand that glasses are never given to actually delay or say arrest the growth of power or the progression of power. See, whatever pathogenesis happens at the level of the eye is to do with the eyeball growth, as I showed in my previous slides. If the eyeball is elongated, you get myopia. If the eyeball is shorter than 24 millimeter, you get hyperopia. So by glasses, you can never alter the growth of the eye. Glasses or spectacles are given only to alter the pathway of the light rays, so that you bend the pathway of the light rays, so that ultimately the image gets formed on the retina. So this answers your question. Spectacles are not given to actually reduce the number or increase the number. They don't have a say in increasing or decreasing the number. They are just given only to neutralize the number at that particular point of time the patient is presenting to us.
So what is the age you want them to wear contact lenses, or you don't want them to wear contact lenses? Because many people opt for contact lenses for vanity, and also for so many other things.
See, as far as the options other than the spectacles are concerned, one has to understand contact lenses have certain indications. The normal understanding is that the patient should be grown up enough. Contact lens comes with a lot of responsibility. Starting from, putting it in the lens case and maintenance aspect of it, sterilizing aspect of it. So it comes with a lot of care. And one should be quite educated enough to know how it works. Like, you cannot wear it beyond a particular stipulated number of hours in a day. So if the individual is grown up enough to take care of the hygienic aspects of it, age is not a barrier, but generally beyond 7 or 8 years, we feel the lowest age group is at least the patient should be minimum 8 or 9 years before you convince them to wear contact lenses. There are medical indications where, ophthalmological indications. Suppose you have a unilateral power in one eye, and the other is completely, so many times we come across children who have -7, -8 in one eye because of developmental anomalies. Okay. The other eye is perfectly normal. It is almost emmetropic or normal. Now, you cannot give glasses which is plano in one eye and having a very thick concave lens in the other eye. You cannot achieve fusion in those cases. So, those are the cases wherein, you have to train the child or the attender or the parent to to put in the contact lens and remove it, or the child has to be trained per se to put in the contact lens and remove it. For uniocular such extreme refractive errors, even at a very young bracket of age, we have to convince them for contact lenses. Otherwise, normally it is beyond say 8 or 9 years.
So, eye being a very sensitive organ, I'm sure their hygiene is what is more important you're going to teach.
Absolutely. See, once, even the fit of contact lens, I'm very sorry to tell you, people are not aware of the exact fit. It's like, it has become almost like an over-the-counter, commodity that is being dispensed. Prescribing contact lenses, one has to be aware of a lot of technical aspects in them. It is actually sitting on the black portion called the cornea. So the cornea per se, the average diameter if you take, it is not the same in everyone.
Exactly.
So ideally, the diameter has to be measured, the keratometry has to be done, the fit has to be checked, whether it is flat or steep, and all the technical specifications have to be taken care of. Only then the contact lenses have to be prescribed, and that comes with a lot of responsibility on the practitioner. The practitioner should be good enough and should take enough time, dedicate enough time to actually train them into wearing it and removing it, and the aseptic precautions have to be, of course, educated, and symptoms of contact lens intolerance have to be upfront explained to the patient. As far as the technical and the superiority of the contact lens with glasses, I do agree. Contact lenses, vision-wise and optically, they may appear to be, superior, or they are in fact superior to the glasses.
Because
glasses
it's just on the eye.
Not only that, see, when you take glasses, what happens is, some amount of minification happens. When we give them concave lenses, whatever object you are actually focusing on appears smaller than normal.
Okay.
And at the edges of the spectacles, what happens is there will be aberration or say dispersion of light. Yes. When it comes to contact lenses, it gives you almost like, near normal vision.
Correct.
That near normal vision, of course, you get provided, you strictly follow to the do's and don'ts. And it reduces the minification. It almost gives a real-time or a near normal size image. And the aberrations or whatever is the dispersion of light that happens at the edges of spectacles, you can tide it over. But again, the aseptic precautions have to be maintained. And always remember, when we get a lot of patients, who go in for contact lenses, having got bugged with glasses, we always tell them, listen, contact lenses are only like complementary to your glasses. They are not substitute for your glasses. What I mean to tell is contact lenses are more so the strongest motivating factor for a patient to go for contact lens is, of course, cosmesis.
Yes.
So during, say, office hours or outdoor work, you can go about wearing contact lenses. We tell the minute you enter home, be judicious enough to remove it, put it in the case, wash your hands, and with all aseptic precautions, put it back in the case and go for glasses.
Okay. So it's not a substitute.
So the emergency vision is still going to be with glasses.
Okay.
Always remember, contact lenses are never a substitute for your glasses.